I'm pleased to continue today's program by welcoming HHS Deputy Secretary Eric Hargan. As Deputy Secretary, Secretary Hargan serves as the HHS Chief Operating Officer, where he oversees more than 80,000 employees in 26 divisions, an annual budget of more than $1.3 trillion. That's right, $1.3 trillion. That's some serious money. From 2003 to 2007, Secretary Hargan served at HHS in a variety of capacities before he became acting Deputy Secretary. During his tenure at HHS, Mr. Hargan has also served as the department's Regulatory Policy Officer, where he oversaw the development and approval of all HHS, CMS, and FDA regulations and significant guidance. He graduated from Harvard and later from Columbia University Law School, where he served as senior editor of the Columbia Law Review. We all appreciate that he made time today to be with us this morning. I'm also pleased he is joining us on the day that we released the high cost of compliance, assessing the regulatory burden on inpatient psychiatric facilities, which you all have seen at your seat. I'd like to give Secretary Hargan a copy of the report for which NABH commissioned Manat Health to conduct a survey of 62 inpatient psychiatric facilities. And now please join me in welcoming HHS Deputy Secretary Eric Hargan. Your official copy.
Sure, absolutely.
Thank you, sir. Thank you.
Well, this could not be, you couldn't be giving this to the right, this is the right person to give this to, actually. Regulatory burden, that's my area. So thank you all for inviting me here today. I've been looking forward to speaking to you because the work that all of you do is vital to the health and well-being of the American people, which is the mission of the department that I'm Chief Operating Officer of and Chief Regulatory Officer of. On a fundamental level, behavioral health providers are a key piece of an important shift that has been occurring in American healthcare over the last few decades. The recognition that behavioral health is health, and the greater integration of behavioral health care into the broader healthcare system. Now, really, that transition needs to be happening faster than it is, but it cannot be happening at all without the work that many of you do to bring access to care for Americans struggling with substance abuse or mental illness. Behavioral health has become more prominent in recent years for two unfortunate reasons. One, the rise of our country's crisis of opioid addiction and overdose, and two, the significant shortcomings of how our healthcare system cares for people with serious mental illness. Today I want to discuss the administration's view of those two issues, and then I'll discuss how HHS is looking at regulation of healthcare providers and behavioral healthcare providers in particular. So again, very timely report. First, no one needs to tell all of you what a crisis our country faces of opioid addiction. You all are on the front lines of confronting this crisis. You're providing the help, care, and compassion that's vital to not only ending the crisis, but also helping people put their lives, families, and communities back together. The opioid crisis hits close to home for me, literally. I grew up in the Midwestern town of Mounds, Illinois. It's a small community of about 800 people at the very southern tip of Illinois. The scourge of prescription opioid addiction first came to towns like Mounds decades ago, as it did to so many other small towns. It was years ago that a very close relative of mine died after a long struggle with prescription opioids, and she was not the last, unfortunately. In fact, when I first spoke of this issue publicly, my family started sending me pictures and notes about others in my family who have suffered and died in the same way. Images of the devastation that drug addiction has brought to my family and to my hometown remain etched in my mind. And while serving at HHS, I continue to keep the victims of this crisis close to my heart, as you can imagine. But opioid addiction is no longer just a problem of small towns like the ones that I grew up in. It is no longer a local issue as it has been in those areas for many decades. As you're all keenly aware, it's now a national crisis that demands action. And President Trump has worked hard to give this crisis the action, attention, and resources that it merits. In fact, as I'm sure many of you know, this is going to probably be the third year in a row that American life expectancy is going down. And not in the face of an infectious disease, not in the face of war, because of the opioid crisis. 3 years in a row that an advanced country's life expectancy is going down in the modern age because of opioids. In fact, it was about a year ago this week that the president launched his National Opioid Initiative formally, which is a cross-government effort to cut the supply of illicit drugs, reduce drug demand, and provide compassionate treatment to those in need. The launch of that initiative followed his call for HHS to declare a nationwide public health emergency regarding the epidemic, which I signed as acting HHS secretary in October 2017. Since then, the president's leadership has secured historic new levels of funding in Congress, as well as unprecedented flexibility for HHS to use the Medicaid program to fund substance abuse treatment in inpatient facilities. Secretary Azar, in turn, has made combating the crisis one of HHS's 4 key priorities, and it has been a top issue for the department, of course, for some time. The epidemic won't be ended with piecemeal approaches, that we know. We need a comprehensive response because the opioid crisis is such a multifaceted issue. This is said a lot in healthcare, of course. This is a multifaceted issue, but it especially applies to the opioid crisis. Every corner of HHS and our health system has to be involved in our response. Now, certainly, as you all know, one of the important tools has to be our payment policies. Since 2015, CMS has been working with states to approve what are called substance use disorder, or SUD, demonstration projects for state Medicaid programs. These waivers give states the flexibility around longstanding rule you all know well, the IMD exclusion, to use federal funds that couldn't otherwise be used to help expand access to inpatient addiction treatment. Now, while the waivers have been around for years, we've now set up an expedited approval process to substantially increase the speed with which they can be approved, and 21 states now have received SUD waivers. This has allowed many of the institutions, possibly in this room, to better serve those needing help, and it represents a really significant historic expansion of federal support for substance abuse treatment. And where we've been able to assess results, which is just at the beginning, they have been impressive. Virginia's waiver was granted in 2016, and an independent assessment of its early effects have found substantial improvements in care and outcomes. States saw a 39% decrease in opioid-related emergency room visits and a 31% decrease in substance use-related ER visits overall, which is impressive. Inpatient treatment exists toward one end of a spectrum of options, from hospitalization and closely monitored residential treatment to monitored outpatient treatment and independent living. Now, it's crucial that the inpatient option be available, but it's just as important that Medicaid programs are supporting medication-assisted treatment and recovery across that whole spectrum. I briefly want to mention another aspect of how we look at substance abuse treatment. While we're committed to fighting the opioid crisis, we know that opioid addiction isn't the only substance abuse problem facing our country. While we typically talk about SUD waivers in the context of opioid addiction, and given where we are now, I think rightfully so, that we place that in that context, the crisis remains our most significant addiction challenge. The waivers are not exclusively focused on opioids. Some states faced almost as great a challenge from, say, cocaine or methamphetamine. Our data suggests that these other challenges are rapidly growing across the country, unfortunately, so our approach to these waivers allows for flexibility and is not focused on treating one single addiction to the exclusion of others. You also know well that substance use disorder often interacts with other mental health conditions. SAMHSA's 2017 National Survey on Drug Use and Health found that of the 18.7 million Americans with substance use disorder, 3.1 million of them also had a serious mental illness. Those 3.1 million Americans with both of those challenges made up almost 1/3 of Americans with a serious mental illness. Now, serious mental illness is a challenge that many of you know well, but it is worth remembering the daunting scale of the challenge that we face. When HHS launched a historic effort to better understand and address this problem through the creation of the Interdepartmental Serious Mental Illness Coordination Committee in 2017, the ISMIC, we had an easy way to sum up the burden of serious mental illness: 10 million, 10 years, and 10 times. It's sort of how we articulated it to ourselves. First, about 10 million American adults in a given year experience a serious mental illness, meaning one that seriously impairs one or more major life activities, holding down a job, maintaining relationships. Second, by one estimate, they live on average lives that are 10 or more years shorter than other Americans, and the number is much larger by some other estimates. It's a tragic outcome for illnesses that we know how to treat. Third, by one estimate, 10 times more Americans with serious mental illness are in jail or prison than in inpatient psychiatric treatment. Now, this is a disturbing and systemic failure of our system. Now, since we launched the ISMIC in 2017, we no longer have 10 million Americans with serious mental illness. According to SAMHSA's most recent national survey, we now have 11 million Americans with serious mental illness, a number that has ticked up in part due to significantly increased rates of SMI among young people aged 18 to 25. So the problem isn't going away. In fact, it's unfortunately growing. Now, one of the key challenges for a long time for treating serious mental illness has been a problem that you all know too well, our lack of options to stabilize patients in crisis, which often involves an inpatient stay. Now, inpatient psychiatric treatment is far from the only solution for serious mental illness. It is not appropriate for many patients, but access to it has been unnecessarily restricted by the decades-old policy known as the Institution for Mental Diseases, or the IMD exclusion. I'm sure most of you know the history of why Medicaid doesn't pay for inpatient mental health treatment. The policy was conceived to discourage states, who traditionally provided mental health care, from offloading those responsibilities onto the Medicaid program. So it was seen as an obvious thing that would be a problem decades ago when this exclusion was set out. But around the same time Medicaid was implemented, now 50 plus years in the past, states were already pulling back on their investments in treating mental illness. Now, often with good intentions, of course, because the support was used to house patients in inhumane, intolerable conditions. However, today we have the worst of both worlds: limited access to inpatient treatment and limited access to other alternatives. Given this history, it is the responsibility of state and federal government, alongside communities and families together, to right this wrong. In short, more treatment options are needed. That includes more inpatient and residential options that can help stabilize Americans with serious mental illness. Now, that is one of the reasons why in November of last year, CMS sent letters to state Medicaid directors laying out how to apply for waivers for flexibility around the IMD exclusion to treat serious mental illness. This was a historic step forward for the agency towards encouraging the use of the Medicaid program to treat SMI. I'm sure its significance was not lost on many of you in this room. As with the SUD waivers, we strongly emphasized that inpatient treatment was just one part of what needs to be a complete continuum of care, and participating states would be expected to take action to improve community-based mental health care. There are effective methods of treating the seriously mentally ill in the outpatient setting, which have a strong record of success and which this administration fully supports. We can support both inpatient and outpatient investments at the same time. Both tools are necessary, and both are too hard to access today. As states take advantage of the opportunity to apply for SMI demonstrations, we hope that all of you can be productive partners in both expanding access to inpatient treatment and supporting high-quality community-based treatment as well. Now, payment is one issue, and it's a big one, but there are many other barriers to getting Americans with SMI the treatment they need, and the sheer shortage of beds in many places is one of them. To address this challenge, SAMHSA has spearheaded an important initiative collaborating with the National Association of State Mental Health Program Directors to create a registry of crisis intervention beds for people with SMI. These beds are critical for caring for people experiencing an SMI emergency. 23 states are currently participating in this new initiative, and we hope to see more states join up. The creation of this registry is just one more indication of the focus this administration wants to put on serious mental illness, and it is a credit to the leadership of our Assistant Secretary for Mental Health and Substance Use, Dr. Eleanor McCants-Katz. Assistant Secretary McCants-Katz has provided key leadership on both of the clinical issues I've discussed today, bringing her deep expertise from the state level and an essential focus on letting science drive our behavioral health policy. Incidentally, she's the first psychiatrist to head SAMHSA, if you can believe that. So she's both a clinician, a researcher, director of a state program, and the former chief medical officer of SAMHSA before coming in as the assistant secretary over the agency. So I think that you'll find that she brings a wealth of experience to this position. I can't imagine anyone better qualified for driving this agency. I'd like to conclude my talk with some thoughts on an issue that affects your work no matter what clinical issue you're dealing with, the need for regulatory reform in healthcare, which is another top priority for this administration. I want to confess something to you today. I like regulation, or at least the process of understanding and reforming it. In my previous tour of duty at HHS, I served as the agency's Deputy General Counsel for Regulations, as the Regulatory Policy Officer, and as the Chief Regulatory Officer. Now in my return to the department, I get to be Chief Regulatory Officer again. I've also taught administrative law and healthcare regulations as a law professor, and I was a regulatory lawyer at my former law firm. So this is kind of my world, hence the right person to give regulatory report to. So you didn't know that, did you? Didn't get the full skinny on where I'm coming from. So exactly the right person to give that to. So regulatory reform, I think it's fair to say, is a personal passion. I have your report here, and as I say, you found the right guy to give it to. Done right, regulatory reform can create an opportunity to examine the barriers that regulations create between providers and patients, frankly, between providers and other providers, and determine how we can reshape or reduce these barriers so that new arrangements, relationships, and solutions can emerge, all while maintaining safeguards for patient access. Now, in recognition of the importance of regulatory reform to paying for value and better coordinating care, last summer I launched a project we've dubbed the Regulatory Sprint to Coordinated Care. And each word's in that were deliberately chosen. It's regulatory, not legislative. So it's not aimed at changing statutes. It's a sprint, at least from a governmental point of view. We're intent on gathering the information we need and moving to rulemaking as soon as possible. Again, as soon as possible. Again, talking about the government and the largest agency in the federal government. It's about coordination above all. We're focused on understanding how regulations are impeding coordination among providers that can provide better, lower-cost patient care, and then reforming these regulations consistent with the laws and their intents. And finally, it's about care. We believe that this effort can meaningfully improve the quality of care received by American patients, including those in need of behavioral health care. Right now, the regulatory sprint is focused on 4 regulations: the Stark Law, the Anti-Kickback Statute, HIPAA, and 42 CFR Part 2. Those are the 4. The one regulation I want to focus on briefly for you today is the one that I think is most directly related to your work, although I'm going to guess all of them are relevant one way or another, which is 42 CFR Part 2. This often is a mouthful for people who aren't really aren't in the sector, and it doesn't have the coolest branding, I will admit, but it is a vitally important regulation passed in order to protect Americans with substance abuse challenges from facing threats to their privacy or facing discrimination in the provision of their health care. But Part 2 became law more than 40 years ago, and today we believe it can be and is serving as a barrier to patients receiving high-quality, coordinated medical care. I recently learned that NABH is a member of the Partnership to Amend 42 CFR Part 2, which I would like to nominate as the most plainly, directly named lobbying group in Washington. So kudos to whoever thought of the name of the Partnership to Amend 42 CFR Part 2, because I know when they come in, they send me a letter, they come in my door, I know precisely what they're there for. You know, if you come in as part of like the Alliance for Health, and I'm sure there is one, I have no idea, but kudos to the namer of that one. As you all are aware, Part 2, which I'll call Part 2, has become a bigger challenge because more medical professionals than ever are getting involved in the provision of treatment for substance abuse. Now, that's a good thing, and it's not something we want our regulations to stand in the way of. More integration of mental and physical health care is a vitally important piece of getting better outcomes for all kinds of health conditions. I visit hospitals and community health centers all over America, and I see the ever-growing co-location of behavioral and mental health services professions with physical healthcare services. Providers have often done this even when it's quite difficult or inconvenient to do so within the physical plant of the facility, because it's seen as necessary for good quality and outcomes. And to see the amount of difficulty that they overcome in co-locating behavioral health professionals shows that these hospitals and community health centers shows the real emphasis that they place and the knowledge that they have of how important this issue is when they bring these things in-house and often sort of displace some of the other healthcare activities that they're doing to make sure that behavioral and mental health professionals are there on site, especially with regard to community health centers, which often have a very limited amount of space. In one location, and with regard to Part 2, I asked a provider how many times she had to provide Part 2 paperwork with regard to one episode of care, and she said 11. 11 times of providing paperwork. Now, that seems excessive, even by Part 2 standards, but that's what she said. So I got to take that as being reflecting at least her real experience with trying to maneuver way around Part 2 when you have a mix of different kinds of providers all trying to bear in on a single episode of care and trying to solve a particular problem. We've heard about all kinds of other concerns as well. As just one example, because providers are concerned that incorporating any information about a patient's substance abuse could make their notes into a Part 2 record, we've heard that they can often be hesitant to take down all the information that a patient gives them about their health. And of course, this is the last thing we want when a physician and a patient need to have the most open dialogue possible about their health, including, of course, any substance abuse challenges. These are just a couple of the many issues that we've heard about. Reforming Part 2 and clarifying the many points of confusion around the regulation will be a boon to all providers and payers who want to provide better quality, more coordinated care. The same goes for a regulation that can be even more important in the context of behavioral health, HIPAA. We've heard tragic stories about how misunderstandings around HIPAA can prevent families from being able to help their loved ones in dire circumstances, whether after a drug overdose or during a psychiatric break. Now, to that end, our Office for Civil Rights already has put out guidance on when and how healthcare providers can share a patient's health information with his or her loved ones when a patient may be in crisis or incapacitated, such as during an opioid overdose. But through rulemaking, we believe we can make even more progress to ensure that HIPAA is protecting patients' privacy and not acting as a barrier to needed treatment and care. So the RFI that we took, request for information about HIPAA, closed relatively recently, and so I encourage all of you to participate as we move forward on any rule that OCR stands out on this issue, because we do intend to take that seriously. HIPAA and 42 CFR both on the information side, stark and anti-kickback on the kind of affiliations and partnerships side. So definitely participate in that. We'll get this more right with more participation on the part of stakeholders who sort of live this on the ground, rather than us we might have the largest single repository of information within HHS. That's what you get for $1.3 trillion a year. But it does also mean we're not in any way, we're not the exclusive repository of the information. We really need to see how these things are likely to play out on the ground and as people are administering care in this area. I want to close out by noting how our overall work on regulation of healthcare providers pertains to all of you. President Trump has made regulatory reform and relieving unnecessary regulatory burden a key initiative of this administration, and we at HHS have participated fully in this. Last year, we achieved over half of all the deregulatory savings for the federal government overall, even though we're only 1/4 of the budget. We deeply appreciate the thoughtful engagement of the stakeholder community in pointing out unnecessary, duplicative, useless, obsolete, not clinically valid, overly burdensome, or other maladaptive rules. We appreciated the engagement of NABH on our Medicare regulatory reform initiatives, including efforts to consolidate and update quality measures. In fact, I'm told when we proposed a certain number of measures we wanted removed for psychiatric hospitals in particular, you came back to us and said that a couple of them, in your view, remained meaningful measures that you wanted us to keep collecting. Now, because our initiative was kind of remove a lot of the unnecessary burdens, but it turns out that, again, a surprise, but a welcome one, which is that people say this is a quality measure that should stay in place. This is a kind of really valuable outcome we can get from good faith engagement with industry and other stakeholders. We couldn't go about this process unilaterally. You understood best what measures were still meaningful ways to differentiate among providers and potentially provide useful information to patients as well. Now, I want to conclude by expressing great optimism for the coming years in American behavioral health care. We have an administration that cares deeply about both substance abuse and serious mental illness, from President Trump to Secretary Azar to our leadership at SAMHSA. Most important, all of these leaders are aggressively pushing a science-based approach to these challenges. This is a value that we share with all of you. You believe deeply in getting people care that's proven to work. You've seen how high-quality behavioral health care can change a patient's life and in turn help his or her family and community. Delivering that kind of care to more Americans is what drives all of us every day. And I look forward, and we all at HHS look forward to continuing working with you in this critical endeavor. So thank you all again for inviting me to speak to you all today. Thanks.
Thank you very much, Deputy Secretary. We very much appreciate your remarks, and we look forward to working with the administration as we go forward. Thank you.